Hello. Good afternoon. Should we wait for more people to join us or should we start? Hmm. Okay, then let's wait a few more minutes because they're coming down and then we start. Let's start with we have a video presentation by Dr. Jeanne Dang. She is president of she is the president and vice secretary of the party committee of the Women's Hospital, School of Medicine in Zhejiang University. And she's also a professor and chief physician of the obstetrics and gynecology in Zhejiang University of School of Medicine. Her presentation will be precise prevention and treatment in birth defects, a practice and scientific exploration in Eastern China. So let's start.
Good morning, respected President Victor, dear colleagues from the Rwanda Society of Obstetricians and Gynecologists, ladies and gentlemen. It's my great honor to deliver this online speech at your annual conference. I am Dan Zhang from Women's Hospital, School of Medicine, Zhejiang University. I'm a clinician and a researcher major in OBGYN, especially in reproductive medicine and birth defects. I finished my MD and PhD training in Zhejiang University and had been trained in Brigham and Women's Hospital, Harvard Medical School, UCLA, and Southampton University Hospital, and so on, for clinic, research, and education. Thank you so much for your invitation. Now let's move to my topic, starting with a brief introduction of our city, Hangzhou, our university, and Women's Hospital, School of Medicine, Zhejiang University. Our hospital is located in Hangzhou, Zhejiang Province, an economically developed coastal city in eastern China, with a total population of 12 million. Zhejiang Province maintains a high standard of maternal and child health. In recent years, maternal, infant, and under 5 mortality rates have all remained at very low levels. Our hospital is an affiliated institution of Zhejiang University, a prestigious C9 university ranked top 50 in the QS World University Rankings. Zhejiang University is structured into 7 campuses containing a total of 41 schools, colleges, and departments. There are a huge number of students, including over 6,000 international students. Of course, we are also proud to host many overseas students from across Africa. Women's Hospital was established in 1951 and is one of China's leading specialized obstetrics and gynecology hospitals. We run 3 campuses in Hangzhou City. There are a total of 1,520 beds. In 2025, we recorded over 2 million outpatient visits and nearly 27,000 deliveries. The number of births ranks among the top 5 maternal hospitals in China. Our national key clinical disciplines cover obstetrics, reproductive genetics, fetal medicine, and neonatology, including full-cycle birth defect intervention through comprehensive clinical services and technologies. Our hospital is home to the Zhejiang Provincial Prenatal Diagnosis Center, established in 1999. It has strong leadership in birth defect prevention, both in Zhejiang and across China. We can offer a comprehensive one-stop service for prenatal screening and diagnosis, covering amniocentesis, karyotyping, and gene sequencing, plus regular MDT meetings for complex pregnancies. Our hospital is China's first affiliate to launch complete ART services, including PGT. The Reproductive Medicine Center has 7 functional departments, and we delivered Zhejiang's first IVF, gift, and PGD babies decades ago. Now let's move to the highlight of my presentation, precise birth defect prevention and treatment. I would like to share our experiences from pre-pregnancy to postnatal care with all of you. What's birth defect? WHO defined birth defects as structural or functional anomalies that occur during intrauterine life. Worldwide, about 6% of newborns are affected by birth defects, and over 90% of these occur in low and middle income countries. As a leading cause of fetal loss, infant death, and disability, birth defect prevention is a major public health priority. Although genetic and environmental factors are strongly associated with birth defects, about half of cases still have no identifiable cause. Given this huge burden, both China and Africa should prioritize precise prevention and treatment in birth defects, I think. WHO advocates a 3-tier approach to disease prevention. In regard to birth defects, we perform primary prevention to eliminate risk factors before conception. Concerning secondary prevention, we offer screening, diagnosis, and fetal intervention during pregnancy. For tertiary prevention, which means treatment and rehabilitation for newborns after birth, I will introduce our practices step by step. Primary prevention is the most cost-effective measure. In China, free premarital and pre-pregnancy checkups, along with free folic acid supplements, are fully funded by the government and routinely offered at primary healthcare facilities. In addition, we also suggest genetic counseling and testing for high-risk families, and pre-implantation genetic test, also abbreviated as PGT, technology for infertile couples with hereditary diseases. Most birth defects are caused by genetic disorders, and some of them are difficult to identify by routine prenatal examinations. Our hospital is also a leader in reproductive genetics in Zhejiang province and across China, and is nationally renowned. We are qualified to carry out a variety of genetic testing. For example, a 1,200 gene expanded carrier screening panel is available in our hospital to identify monogenic diseases. Hearing impairment, as an example, I noted a study in Rwanda found 23.6% of cases to have a genetic cause. Another example is spinal muscular atrophy, also known as SMA, a hereditary neuromuscular disease our panel can also detect. We have leading pre-implantation genetic testing PG technology to control this disease from early life beginning. Our hospital offers leading-edge prenatal screening, including NT screening, NIPT testing, and serological screening, as well as precise diagnostic technologies such as prenatal ultrasound, fetal MRI, and genetic disease diagnosis. In China, these services are only approved at qualified hospitals such as those at the prefecture and provincial level. We pioneered China's first fetal medicine MDT team. We have mastered 11 fetal interventional techniques and completed more than 900 intrauterine surgeries, with the world's first radio frequency ablation for a fetal posterior neck tumor, China's first exit surgery for sacrococcygeal teratoma, and multiple provincial pioneering fetal interventions. Next, I'd like to focus on our landmark technological breakthrough, the upgraded NIPT Plus technology, published in Nature Medicine in January 2024. Led by academician Professor He Fenghuang and Professor Jinglan Zhang and me, our team completed a prospective multi-center study covering 1,191 pregnant women. Compared with traditional NIPT technology, this upgraded NIPT increases in detection of clinically significant pathogenic variants by 60.7%. A single maternal blood sample can detect 7 aneuploidies, 9 microdeletion syndromes, and 75 monogenic disease genes of fetals, greatly expanding non-invasive screening coverage. Our hospital has advanced imaging technologies such as 3D and 4D prenatal ultrasound and MRI. Annually, we perform over 10,000 prenatal ultrasound examinations and around 3,500 fetal MRI scans. We established standardized fetal MRI protocols to analyze hemodynamic changes in fetal congenital heart disease. We contributed a chapter to Springer's professional monograph and published relevant findings in top journals. Our hospital is also a national unit for integrated maternal fetal medicine management of fetal congenital heart disease. Now we turn to tertiary prevention for newborns. Zhejiang Province provides universal free screening covering over 99 genetic metabolic diseases, free hearing screening, and congenital heart disease screening via the double indicator methods, cardiac murmur combined with pulse oximetry. Affected children receive timely surgery and long-term rehabilitation to reduce permanent disability. Our hospital has leading neonatal technology. We have successfully saved a baby born at only 22 weeks gestation with a birth weight of only 475 grams. Our LISA, also known as less invasive surfactant administration therapy, first validated via controlled clinical trials in China, has rescued over 500 premature infants across Zhejiang Province and Eastern China. We are one of China's first national talent training bases for birth defect prevention since 2018, supported by the National Health Commission, NHC. We have trained more than 1,700 medical practitioners from over 100 hospitals across Eastern China. Coverage of both pre-marital and pre-pregnancy counseling now exceeds 90%, and over 95% of pregnant women receive prenatal screening. Last year, 38% of total birth defects and 95% of fetal malformations were diagnosed prenatally in our hospital. The neonatal screening reached 98%. These efforts have led to a decline in fetal malformations. In Zhejiang Province, the incidence of NTD, Down syndrome, gastroenteritis have fallen below 1 in 10,000 perinatal births. Over the past 5 years, we have trained over 1,000 medical staff, strengthening clinical capacity across the region. We had achieved the government's goal of country-level screening, provincial and municipal level diagnosis. Part 3, scientific exploration of our team. Our scientific innovation is anchored by more than 20,000 square meters of dedicated research space across 2 campuses of our university and 3 campuses of our hospital. We established a clinical trial ward, the Institute of Medical Genetics and Development, Basic Research Lab, and Animal Centers, which greatly support our clinical and basic research exploration. This infrastructure underpins our priority research areas, from fertility and birth defects to maternal and infant safe technology. Through a network of basic research and clinical research platforms that turn discoveries directly into patient care. Let me share a few recent research highlights with you, starting with reproductive medicine. Our multiple center RCT published in BMJ in 2025 found that for couples with severe male infertility, PGT-A does not raise the cumulative live birth rate, but significantly reduces the risk of miscarriage compared with conventional ICSI, guiding more regional evidence-based use of PGTA. Our three-tier system is strongly supported by our Reproductive Medicine Center. We are the first Chinese hospital to offer the full spectrum of ART technologies and have built the nation's first long-term follow-up cohort for IVF children with more than 8,800 participants. Our core proprietary technologies include PGT-M for preventing the transmission of monogenic diseases, combined with PGT-PRS for hereditary breast cancer risk prediction. Our cell-free DNA screening technology improves pathogenic variants detection by over 60%, and we conducted pre-implantation testing for 47 of 121 rare diseases listed in national catalog. Many of our research outcomes have been cited in international clinical standards. My joint research with Professor Hongqing Liang, published in Science early this year, uncovered how endogenous retrovirus MLT2A1 regulates human egg cell embryo development by forming heterologous chimeric RNAs with expanded genome targeting capacity, offering a brand new insight into overcoming unexplained human embryo development arrest. Another RCT led by myself in collaboration with Perkin University and the University of Sydney teams on vitamin D supplementation before IVF in women with PCOS was published in BMJ this year. Among 876 patients from 24 reproductive centers, high-dose vitamin D significantly raised serum vitamin D levels, but did not improve live birth rates of the first transfer cycle. On the other hand, the cumulative live birth rates in 12 months was increased in the subgroup with high vitamin D level, providing high-level evidence against unnecessary supplementation for infertile women. Beyond the laboratory, we translate discovery into maternal and neonatal care. We established China's first subspecialty in fetal medicine and pioneered its MDT model. We are also the international center performing the largest number and the most complex uterine repair surgeries during pregnancy, including China's first such case. And we lead the country in the range and expertise of fetal intrauterine diagnosis and treatment, including the world's first radiofrequency ablation for a fetal posterior neck tumor. To close this section, let me introduce our newest initiative, the China Baby Omics Project, led by academician He Fenghuang and me as a co-PI. It aims to build a public neonatal database, including not only health and disease information, but also multi-omics data spanning genomic, metabolomic, and proteomic data, and so on, for 1 million Chinese newborns by 2030, filling a major gap in neonatal multi-omics research and providing crucial baseline data for global birth defect studies. We maintain long-standing academic cooperation with over 20 top universities and hospitals across 5 continents. We have built 4 international joint research platforms with partners from USA, Canada, Belgium, and Hong Kong to carry out cross-border reproductive and neonatal medicine research. Among all our global partners, Rwanda is especially important to us. Last year, President Victor visited our hospital and signed an MOU with us on December 8, 2025. We reached agreements on long-term academic exchange, technical training, and joint maternal child health research, which brings us together for today's exchange. Looking ahead, in line with UN Sustainable Development Goal, our hospital looks forward to working closely with RSOG and medical colleagues from Rwanda and across Africa to advance this shared mission. To give a healthy baby is the wish of every family and every country. Healthier mother, healthier world, babies, and a better world. We hope to, through sustained exchange and long-term collaboration, working together to improve maternal and child healthcare standards across Rwanda and China. Thank you so much for your attention.
I imagine this would be rather very helpful to have some kind of premarital and prenatal screening for this type of birth defects. This is really. I would like to introduce our next speaker. She is Dr. Jen Liu. She is the General Manager of the Birth Care in Hangzhou Medical Technologies. She's also a member of the Joint Working Group in the Maternal and Child Health Care in China Africa Hospital Alliance, and she has devoted her time to maternal and child health for more than 15 years. Her presentation will be on innovative solutions for maternal and child health from China to Rwanda. Welcome, Dr. Jane Liu.
Thank you. Okay. I'm Jen from Hangzhou, China, and it's my good pleasure to presentation. And thank you to Dr. Pavitt. Many thanks to my invitation. The topic today I bring here is the innovation. Is the innovation solution for maternal and child health from China to Rwanda. And this project has been led by the China Africa Hospital Alliance and the Joint Working Group on Women and Children's Health. And with technical support unit is the Zhejiang Women's Hospital, and the implementation unit is the Birth Care Hangzhou Medical Technology. Let me introduce the working group. The Joint Working Group on Maternal and Child Health of Africa China Hospital Alliance was established by the International Health Exchange and the Cooperation Center of the MOH of China. It is committed to promoting and implementing cooperation programs in the field of women's and children's health. The working group with the aims to facilitating the sharing, transfer, and localization of the technologies in Africa countries. And it's also cultivating the group of professional and technical experts. and then working together with African partners to improve maternal and newborn health and safety, to enhance the quality of maternal and child health care services. Then promoting the suitable development of maternal and child health in African countries. And the technical support unit, Zhejiang Women's Hospital, is one of the leading hospitals in East China. This hospital is the first batch to establish the prenatal screening and the prenatal diagnosis system. And with a set of efficiency management systems to serve the maternal and the women's health, with the advantageous disciplines of genetic, reproductive medicine, maternal medicine, and birth deficiency prevention. Dr. Zhang Dan is the director of this hospital. She came here last year, but couldn't get the visa this time. The implementation unit is the birth care Hangzhou Medical Technology, and this company has focusing on maternal and child health services for more than 25 years. It has conducted the screening tests over 200 million samples, and with 70% coverage for maternal and newborns in China. And it also serves more than 1,000 NAPs, 1,000 birth deficient prevention and treatment centers. Birth care takes not every mother to be more happier as its mission, and birth care built a smooth quality control system to empower the hospitals. Then let me introduce some birth deficiency prevention experience from China. In the past 30 years, China has built a 3-tier birth deficiency prevention system. It means that in the primary prevention, when women enters the childbearing age, she can get the preconception screening to identify the high risk of developing serious genetic disease. If it's positive, she will get the further diagnosis and counseling from experts. For the secondary prevention, is built for the pregnancy women. They can get the serum screening and NIPT for downstairs, and some other check for other diseases such as CHD, NTDs, and the diagnostic platform can be available in the prevention hospitals. The tertiary prevention is for the newborn babies. Traditional 4 diseases such as TSH, PKU, G6PD, 17-OHP can be conducted, and the metabolic disorders are on the LC-MS platforms. Then the solo gene disorders can be tested on PCR next generation sequence and the 3rd generation sequence. Some confirmed cases can receive treatment timely. For improving the quality of birth deficiency prevention, the Chinese government announced many laws, regulations, and standards. The core national laws are the Law of People's Republic of China on maternal and infant health care administrative measures, for the implementation of the maternal and the infant health care law. It was announced in 1901. For the last 25 years, and it has built a very smoothly system to control and to make a more healthier birth. And the second basic medical and health promotion law of the People's Republic of China has been announced 2020. Until now, the 4 diseases screening rate has arrived to 99.99%, and the 29 metabolic disorder screening rate has arrived to 18%, and with the Down syndrome screening rate to 93%. And since 2009, folic acid supplementation has been provided to everyone for free and to prevent the NTDs. China has also built the standard consultation and has the important work for the Health China 2030 strategy. There is a successful case of Guangxi province for the thalassemia prevention model. Guangxi is in the south of China and with the high carrier rate of the thalassemia gene. For decreasing the thalassemia rate, they have finished much work with the milestone that in 2010, the government need full coverage prevention has been started. And to 2016, the mutation of the Guangxi protocol for curative treatment. And to 2018, the zero silver thalassemia births initiated launched. And to 2025, it has get the target. And the model has been introduced to other Asian countries. And in 1926, the breakthrough in gene editing cultivator therapy has been used to some serious patients and get good treatment results. And now, today, when we focus on the birth deficient prevention system, there are still some challenges in Rwanda. The CHD, Down syndrome, NTD are high rates in newborns, and so does the sickle disease. All of these diseases are serious and not only directly threaten the survival of newborns, and also bring heavy financial burden to society. And maybe it could create long-term public health pressure for social development. Maybe we need the nationwide standard for pre-pregnancy health care. The folic acid folification policies and the nutrition supplementation coverage need amplified. The high-end prenatal anomaly screening needed be more available. Animal genetic metabolic diseases need to be detected early. And the unified newborn screening network need to increase the quality and make the screening work under control. So what we can do together? We need to build a whole process control system with the instructions fully passed down from the MOH, pass it on to provincial hospitals and administrative departments. then go to the next level hospital, even to the community hospitals. And the screening samples come from the community hospitals and gathered to the test center to keep the quality be controlled. Positive cases can be get diagnosis and treatment timely. We can also do some training to improve the clinical capacity in genetic counseling and research. We can do some research. Doctors from Rwanda can be sent to China for training and communicating. China doctors also can come to Rwanda. We can have more communications about diagnostics and treatment. Also can build some counseling standards. We also can do some in-the-hospital collaborations for clinical care and for the severe patients. We also have some solutions for the deficient We have multi-platforms for the birth deficient prevention, such as for the prenatal screening platforms and for the prenatal diagnostic platforms, such as NIPT, Next Generation Sequence. And we also have the neonatal screening platforms for the fall disease and metabolic disorder diseases. For the 6L testing, we also have a test card. And this test card with the method of microfluid PCR, it can be directly to diagnosis for the 6L, and it can be done with no electricity and with no other instruments. It can be used simply, and it may be more available for the community hospitals and for anyone needed. We also have the fat heart monitoring, and the fat heart monitoring solution. One can use inside the hospital, and the smart one can be used outside the hospital, and the smart one can be used maybe in the community hospitals, and it may be more available for pregnancy women. And it was the AI assistant result analysis, data analysis. This model has been popular in many countries, also in China, and it is more useful. This device is for neonatal children's meter, and we know that for the newborn babies, students, it's very normal, and these devices can use it to test three points. The head, face, and chest. Then it can read the average date, then give the result. It is very easy to use. For the G6PD, it's a POCT card, and can be used very simple. And for the newborn children screening, and maybe for the acute hemolytic anemia. We also have the neonatal screening information system. This system included the whole processes such as samples delivering and testing, then the diagnosis, the treatment, the recall, and the reproductive reproductive guiding concerning. And we also can provide all the services or the training classes for the users. This software, this system has been used in many provinces in China. Yeah, they use the system to control the screening quality and to store the date, and then to take the information report to the government and make the government can know it timely, and to do some research, then do some actions. Yeah, this is the software can be used to government, to the hospitals, and then to doctors. It's very useful, and maybe we can change the language to the local language and help our hospitals how to use it, and to keep the information to be more right. Yeah, all of this work has been done for a more healthy maternal and more healthy childhood for our country. Let's every mother enjoy happiness is our vision. Thank you very much. Thank you. Yeah, we took 2 instruments to Rwanda, and I will give to the gift to Dr. Pavitt.
Thank you very much. Shishinin. Yes. Okay.
If you allow me to say something, so the Women's Hospital is where I did my residency program. And Dan Zhang was my teacher before she became the president of the hospital. Yeah. So I thank them for accepting our invitation. It's a very nice university. It's a top 3 university in China and top 10 in Asia. So it's like the Harvard of China, if I would say. Yeah. So whoever is here and is interested and want to connect with them, please. And Kiara, I can see you're interested. Please reach out. I'm ready to give information for students who would want to go for master's program or PhD, anything. And also work with them as they are into research, and also have products for basic research. If you want to know how to do like the buffer, the PCR and all, please reach out to them. They will give you more information. So thank you, Jen, Leo, and Jiming for coming. Agenda Hankausing.
Thank you very much. We may have some questions from the audience. Whoever wants to ask a question can make themselves known.
Good afternoon, everyone. My name is Dr. Riziki. I just have a brief question on the neonatal non-invasive jaundice meter. So first of all, I think it's really useful because none of us wants to do serial venipuncture for neonates, especially when you're monitoring bilirubin levels. So I've had some concerns about its use in dark-skinned babies, that it's not very effective in black babies who have a darker complexion. So I was just wondering, maybe you could explore a bit about that and the accuracy across darker-skinned babies. Yes. Or people with color, rather, yes. People of color, sorry.
Sorry. Would you please conclude your... Yeah.
Our skin color is dark.
Oh.
So how are we able to detect that jaundice?
Mm-hmm.
Yeah, that's what she's asking.
Because the machine I more familiar, so let me answer your question. We have done some research. There is nothing about the skin color. Yeah, no matter you are white or yellow or black, you can use this machine, and it can give you the accurate data. So don't worry about it.
It can be used in our Chinese medical team, and they will have a try in Rwanda, and some data has been pretty. Yeah.
Thank you. Is there any more question? And if none, thank you very much, Jen Liu.
Very much.
Thank you very much for the great presentation. And I think we've all seen how much all this technology looked impressive. And it would really be nice if we could have access to it as well. But thanks already for letting us be aware of the instruments. So thank you very much for the attention you're giving to the presenters. Next up, we have 2 oral abstracts, and then we'll have a plenary session for the day. The first oral abstract is about Transform 2030, advancing country-led financing to strengthen health systems for women, children, and adolescents. Please give a warm welcome to our presenter. He's a physician, a public health leader across Rwanda and East Africa. He's now the Global Financing Facility Country Coordinator with the World Bank. Please help me welcome Dr. Anaclet Ngabonzima. Thanks a lot. Welcome, Doctor.
Thank you so much. So again, I'm going again to disturb you with health financing. I know again that I disturb you with health financing again. Because whatever we are doing without enough resources, it can't work. So it can't work. I think I should go on the other side. Yeah. The Transform 2030. You will hear Transform 2030. It's normally it's the common name or Christian name of the GFF strategy, covering 20. That's the next one. That's for the Transform 2030 is the GFF strategy covering the period running from 2026 to 2030. So it's the other name. So that's something which has been elaborated based on extensive review of what has been achieved over the past 10 years since GFF was initiated. And I guess everyone has understood what GFF is. I will try to avoid presenting some slides. So now, so I think I talked about most of these. The way GFF is housed at the World Bank. So how it was created in 2015 and why it was created and how it leveraged money from behind the World Bank money and try to mobilize resources, but leveraging the way World Bank is providing money to countries. So that's the general principle that I have talked about this one, and I don't want to really to focus more on this one. But as a reminder, is that GFF has mobilized 2.5 billion across 10 years, last 10 years, which mobilized 11 billion from IDA or IBRD of the World Bank. So that's what I said. And remember that the target of the GFF is not to provide the money for being used like that. So it is used, of course, to improve RMN such services, but the primary target is to unlock funding of the World Bank to be invested in health by countries. is to unlock funding. That's the primary. And then when it is unlocked, together they use this funding to improve services. So, I think this one we talked about how GFF eligible countries but not yet supported have really declined in terms of using AIDA money into RIMNCH in the last 10 years, while GFF supported countries have again increased 25% of the budget of AIDA, investing them in RIMNCH. So if you that's the median of you will see that slide. It shows you that's the median of AIDA allocated to RIMNCH services across on the other side across the GFF eligible countries. GFF supported the countries. It increased. Is this working? This one? The pointer. I can try. I avoided this one. You will see that this was the median of the AIDA money invested in RIMNCH for GFF supported the countries. So this is pre-GFF. This is after GFF. So the money invested in RIMNCH, the money from the old bank that the countries supported by GFF put in RIMNCH has increased more. But other countries not yet supported, the money they are putting, it is decreasing. So if those countries, they account more maternal in child death. If this continues like this, maybe after 5-10 years, countries may no longer invest in RIMNCH. And you understand what can happen. So GFF plays like a catalytic funding, pushing countries to invest in RIMNCH services, just to benefit also from the grant of GFF. So that, I think I have talked about this one before. Now, the problem now is that there is a progress, there have been global progress on reducing maternal and newborn child adolescent death, but recently, you know, there has been a kind of the decrease in terms of the decline in terms of fiscal. The funding is decreasing, is really declining, and this is something we have always to think about. And I think this may continue in next few years. And remember, when it is like a shock, we may observe the progress we have been seeing. It may be the other way around in next few years. So the under 5 mortality in GFF supported countries reversed a slower than global reduction rate in 2015, but into a faster one. So the countries supported by GFF, they have really reduced the annual reduction of child mortality has really increased when GFF was introduced. That has been the same for maternal. You will see this on this slide. Now, if you look at this was the under 5 mortality reduction. This is under 5 mortality reduction. The annual reduction. You see, this is before GFF. This is before GFF. This is after GFF. For countries not supported by GFF, the annual reduction in the period of GFF has been reduced. But this is a reduction during the GFF countries, for GFF supported countries after introduction of GFF. So the annual reduction of maternal mortality, maternal mortality has really increased substantially compared to countries not supported by, which are not benefiting the GFF funding. But once again, it's not the GFF grant which is supposed to make a difference, but the money unlocked by GFF funding to make to contribute to make a difference. Together, of course, but GFF alone money may not change anything, but the mechanism itself can change something based on how it will unlock money. So now, the problem now is that without more predictable country-led financing and stronger PHC system, countries risk falling further behind RMNCH goals. That's what I was talking about. So the GFF strategy aims to respond to 5 key shifts, strengthening progress in GFF eligible countries. Which ones? Number 1, we are facing the slowing progress of and widening equity gaps in health and nutrition. Number 2 is backsliding on SRIHL and gender equality. Then there is a severe global and domestic health financing constraint that we have been facing since like 2 years. Then there is also increasing fragility, conflict, and climate risk. And then finally, a looming jobs crisis for young people and women. For the World Bank, when we talk about the fact that people are not finding jobs, behind this one, there are adverse maternal and newborn outcomes. Behind this one, behind the lack of jobs. At the World Bank, people, they look at everything. So now, the GFF transform strategy, the GFF new strategy tends to mobilize country-led financing to strengthen health systems for RMNCH, and it is built on the lesson learned. That you have been on the lesson learned, that GFF supported countries have achieved the faster reduction in maternal and child mortality than the global average since 2016 when GFF was introduced. So evidence that country-led financing accelerated result and justify scaling the model. Now, what are now, based on these outcomes and findings or analysis from the over past 10 years, now GFF elaborated the strategy covering the period up to 2030. Now, what do we want to do? They have been reviewed a decade of GFF implementation data, independent evaluation, and synthesized the global strategy consultation with partner country governments and development partners and civil society, and then data were translated, and then people were trying to develop a strategy responding to the findings. Now, what is there in the new strategy? In the new strategy, with the only three objectives, one is that GFF wants to maximize the World Bank financing for RMNCH and nutrition. And in nutrition, maintaining or exceeding the ratio 1:7 IDA average ratio. I think I explained this one, that for every $1 of GFF, it has to unlock $70 from the World Bank, from IDA money, to be in the health sector, specifically for RMNCH. It's not only $1 that can change things, but the mechanism itself. Number 2 is to support the countries to bring more external resources on a budget and increase alignment with country systems. So now currently, GFF within the World Bank is trying to work with other donors to say, for example, it is called the joint financing framework. Now, Global Fund, how can we now support this mechanism, this intervention for Rwanda together with you? Then, together contributing to this one, bringing the money but through own budget. Because the own budget, when most of the money from partners which are not on budget, sometimes the country cannot know. But when it is on budget, sometimes the country know exactly what is being spent on what. Number 3, that is what we call they extend the joint financing framework to all eligible countries. So they want to intensify support to strengthen national planning, budgeting, and the prioritization of cost-effective health spending, and then unlock more domestic resources for health through smarter spending. There are now different mechanisms. I will tell you some of them that GFF want now to create and see how how health financing can be better. Number two is accelerated delivery and access to commodities. As you know, no commodity, no program. Maybe for Rwanda there is no more issues on commodities, but many countries are facing issues related to commodities. So if you don't have oxytocin, even if you have very good midwives and gynaecologists, you can't do anything. There will be, if you can't manage the third stage of labor with, or just preventing with oxytocin, you can't do anything. So GFF now wants to solve the issue of lack of commodities, through which mechanism that I want to talk about. This number 3, that's what we call New Sustainable Commodity Access Challenge Program, SCAP, to strengthen family planning and MSH commodities. This one will work how? It's just $3 of domestic funding, GFF add another $1 to procure commodities. So if you have money, so now it has 250 millions US dollar, but this one must unlock 1 billion. 1 billion because it's 1/3, it's 1/3. 250 million now available, but the target is not to buy commodities only with these 250. No, it is GFF seems to be clever. No, we will buy them, but mobilizing 750 millions US dollar to have a total of 1 billion commodities, but 750 being now domestic funding. It can be from the World Bank or other partners or the government money. So I'm about to finish, and we have number 2. I talked about revising the eligibility countries. I talked about this one, that now we stay with 56 countries, and higher grant allocation possible for the highest and very high burden. This will continue. These 5 years, there will be more based, compared even to previous 10 years, there will be more funding again, but based on again on the money which is unlocked. And finally, new innovation. There will be new innovation. GFF tends to fund the scalability of new innovation. We talked about SBBC before. That is one of the 6 scalable solutions for SBBC, for GFF. And for example, GFF has got the challenge fund for SBBC, but it is based again on availability of domestic funding to top up again. And finally, we have priorities include that's the priority. The aim is to reduce maternity-born mortality. So there are some cross-country enablers. Cross-country enablers include, for example, the availability of the tools to ensure that there is availability of the data for evidence-based planning. I talked about FASTER. This is a frequent assessment and system tools for resilience. Where it is, for example, you can have phone surveys and replace harmonized health facility assessment to see the availability and readiness of services across the just using phone surveys. This is an example, and it is really working. Where countries are using it, you can see always. Sometimes we blame health facilities while the readiness is almost the readiness is compromised, and we intended to equip countries to sustain essential services during shocks, and bolster the health workforce as an engine on job creation. We integrate gender and equity and deepen all the bank partnership and strengthen results for measurement, and then secure sufficient funding to deliver the strategy through a new resource mobilization campaign. For your information, in April during the spring meeting, GFF, for example, in one day mobilized $800 million US, just in one day, because people they use the old bank existing system in mobilizing partners within the old bank system. It becomes, because they have the confidence that this money will use the tough procedures of the old bank, it becomes a bit easier to mobilize money. So in brief, this is how it is. This is a decade of GFF result which shows that the country ownership works, and Transform 2030 builds on this, on the previous achievement to end preventable maternal and newborn and child death. And we think that primary health care remains the most effective platform to reach women, and the country-led financing and the stronger PHC can accelerate progress on RMNCH. So that's how it is. I don't focus on these recommendations. They are based on this one. But I can't go without, again, talking about scaling up proven high-impact interventions like a safe birth bundles of care without delaying if we want really to progress the reduction. I always give example before. When you look at newborn mortality being reduced from 20 for Rwanda in 2015 to 2019 after 5 years, and then to 2017 in 2025, the simple meaning is that intervention we have are not working. That's the meaning. They are not working, so let's now introduce new evidence-based interventions. So otherwise, what will happen if not done? You see, when the indicators are plateauing, they tend again to increase. So thank you so much. I really thank you so much for your kind attention.
Yes, thank you. I think you can wait here for we can.
Yeah.
Great.
Thank you very much for the orientation on GFF. I have 2 questions. One, Ministry of Health seems to be the backbone that you work with. We have a devolved health governance system where you do not have solid leadership at the top, but within the devolved system in the counties, in my country we call it counties.
Kenya.
In Kenya. Is there a possibility to tap into GFF at county level? 2, tell us, how can the professional bodies plug in to GFF? I think that's the most critical thing, because right now we have this push for every woman, every newborn, everywhere towards SDG 3 by 2030. We're aligned with you, but how does the professional body tap into this?
Thank you. I think it is a similar question, actually. You've got a triangle of players, GFF, the World Bank, and then the beneficiary, correct? Now, what kind of mechanism do you have to influence the outcome of the monies you're spending to the people? That's number 1. Number 2, what do you gain after giving away that 1:7 ratio?
Come again for the last one?
Yes. What does GFF gain after giving away the 1:7 ratio money?
That's very interesting question. So do you, the last one, you mean what GFF will gain in giving 1/? Yeah, the target. Let me start with this one. Remember, the target of GFF is to unlock more funding for RMNCH services. Because the primary objective is to support reducing maternal newborn child mortality. So that's the primary target. So now, but through what they know that there has been an issue with financial resources. So the target is to unlock more funding to be invested in RMNCH. Because where countries not supported by GFF, they have reduced the money invested in RMNCH. And of course, together, indicators have worsened. This is across over 10 years. So GFF tends to say, now, let's now provide more funding, more funding to countries to invest in maternal, newborn, and child adolescent health. But which ratio? The ratio This is 1/7. This means 10 million over when it, or 70. How it works? The rationale behind this is simple. As I said, many countries, they use the money of the World Bank. And we say your World Bank, we mean IDA or IBRD. They take the money in the form of loan. We call this concessional loan. When it says concessional loan, there is either zero interest or like 0.025 interest. It's like there is no interest on this one. With the grace period, this is how it works. But the country has more priorities. The countries, they have more priorities. When you ask the Minister of Finance, we have 7 millions of US dollar as a loan. They will say we will put 100 million in education. 100. They can forget health. They can forget. Many countries, they don't fund health with this money. So now, but when we tell them, you tell them that remember, this is the loan you will be paying back. They may say now, because we will pay back, we will focus on this on the roads. Then we add this one. Then we go to building the rooms of the classrooms. Then we don't put the health because the health has some other partners. What did GFF do? GFF now tell you, now, if with this money of IDA, remember, for me, I have also 10 million there for grant, which you will not pay. But conditionally that you invest some money on IDA also in health, on alignment search. So then, the minister will go and say, am I going to lose really 15 million that I will not reimburse as a grant because I don't invest in health? They go, they think twice, and they decide to have a project on health so that they can benefit the grant. That's how it works. And we say, that's how it works. It's the ratio. But for us, the ratio is normal. It should increase. We should say it should be $1. If it is 1/10, for us, it's better if we increase this ratio. It can't be 1:1. If it is 1:1, it's like I give you 10 million, you invest 10 million. So this is nothing. Yeah, that's how it is. So if I come back to, the GFF funding is within the health. For your information, if there is no project on health, there is no money of GFF. That's how it is. That's how it works. If there is no project on from the World Bank on health, GFF, you cannot categorize zero. You cannot come and top up on zero. This is not a top up. It is called additional financing. So with regard to counties, Mari, when you say the country-led mechanism, health financing mechanism, it means that you give power to the country. You give power to the country. The client of the World Bank, the number one, is the government. And the government is big. Government is not something, is big. So today, if you say, let's start everyone coming, you have seen, for example, that GFF has supported the SBBC in Tanzania directly by application grant. This is something which may come to scale up some intervention. For example, in Tanzania, they have open application and they receive the millions and millions to scale up SBBC. This can happen. But the most of the money is RITF. RITF is recipient executive trust fund. This is the money on budget managed by the Minister of Finance. It is additional financing, but coming to complement the money that the country will pay back. The GFF, they will not pay back, but the one it is accompanying, it will pay back. So the Minister of Finance must know what is going on. That's why. But when it is there, the ministry can decide during the planning, give money to professional associations. It is not prohibited. When the money is within the Ministry of Finance, it is not even the Ministry of Finance like that one. For example, in Rwanda, it is within RIBC, SPIU. They can plan even to give it to community health workers. It can happen. It can give it to professional association. When there is a planning, that's where it comes. It is important. When we are planning for a project, is where we have to consult each other and see whether during the implementation, RBC may provide the money to professional association to strengthen this. For example, we are we start thinking about a project on a primary health care. But this one may be given money to 4x4. If it is a 4x4, it will be RSOG. So, but everything is decided. We don't bring money and a company and saying, do this, do this. The World Bank cannot do that. So I don't know whether that's how it is. That's how it is. And you remember, World Bank doesn't have staff to implement. You will see, we have 2 people for health everywhere, or 1 person. No implementation, government-led. So, but remember, sometimes the money that is paid back, our children may be paying back some millions. Though it has to be like that. So, okay.
Thank you very much, Dr. Anaclet. This was a really great presentation and one of a kind throughout the conference. I hope some people are realizing that some doors are being opened. So this is great. This is great. I think a lot of people are going to require his contacts. Please allow us to share your contacts as the organizing team. Thank you very much. I wonder if we were going to have a second presentation with Dr. Melkamu. I did not see him previously. I wonder if he's in the room. No. Maybe somebody knows where he is. Maybe he stayed up, not understanding. Okay, great. So next up, we have a plenary, a presentation and discussion. It will be about geriatric gynecology, menopause, and aging disorders management to optimize women's health across the lifespan. This is a great talk, and our moderator for this talk is someone we know. We've seen him earlier. He's a gynecology and obstetrician. He's a specialist in family planning and gender and reproductive health. He's the only specialist, I think, currently in the country. Others are joining him very soon. Please help me welcome Dr. Polyphile Niyinyurgu. Welcome, Doctor.
Thank you so much. Maybe we should warm up a little bit. Maybe let's warm up a little bit. It's been probably some minutes of sitting down, okay? And it's cold. It's winter in the middle of summer. Let's stand up and stretch a little bit, okay? Okay, stretch a little bit. Okay, try to stretch, reach out to all these maternal health issues. Okay, and please take them down. We want to take them to 0. Okay, expand access to all healthcare, universal healthcare coverage, accelerate the progress. All right, good. Okay, now let's celebrate the success. Thank you so much. Okay, I thank you so much for another wonderful discussion. So the next one is going to be another beautiful one. So the decade of 2020 to 2030 has been declared by the World Health Organization as a decade of healthy aging. Who doesn't want to age healthy? And they say, if you are really smart, you're looking for opportunities, you don't actually look for opportunities for the moment that is in motion. You don't look for today, if today is in motion. Because today will pass, and tomorrow you are in a place that you did not want to fund, to improve. Now, today is already existing, And tomorrow is where we are going. We are going to, our panel of today is on healthy aging, geriatric. But today, I want to call it what we call it in OBGYN, midlife and menopause health. We have our colleague here, Dr. Byiringiro, who is going to give us a quick presentation. Dr. Byiringiro is joining us from King Faisal Hospital and is a consultant obstetrician and gynecologist. And he is actively engaged in both clinical practice and research, contributing to the advancement of women's health and reproductive medicine in Rwanda. He is also a fellow in reproductive endocrinology and fertility. Dr. Byiringiro, you're welcome.
Thank you so much, Dr. Polyphile, for this beautiful presentation on me. As I said, my name is Jean-Paul Byiringiro, and I'm obstetrician and a gynecologist, and highly interested in reproductive endocrinology. So allow me kindly to present on menopause and what is needed to promote it in our country, and how can we manage our women reaching this stage of life. So as you see, this picture is showing us that if we take care of our women, not only for them to benefit, as well as men will benefit. Because our sexual life is part of our life. So our women, they are ours and they are theirs as well. So how will you approach our women in the post-reproductive age? So staging them, it's a good matter, because you will know how to approach them as their management is individualized. So that's where you'll see some of them, they reach out this stage in the early, that we shall call early menopause, others in the late, others at the right time. So what is the right time according to the WHO and the other evidences? The right time for menopause, the mean age for menopause, all of us we know, it's around 51 and a half. So, but regardless of that, so from our experience, we are seeing many coming in the early age than that, complaining the same symptoms as well as the people that are supposed to reach that stage of life. So here I want to show you how people can suffer. How people can suffer if we don't intervene. So once you have reached this physiological state, so some of them, they call it a disease as well, but it's a physiological, but turning maybe into a disease because it can harm our people. So if you reach it early, you can see how many years you will suffer if there is no intervention. So in early, if you reach it in early, it means your ovaries, they are no longer producing these steroid hormones that can support you. You will see you can spend 11 years in a desperate life. As you reach it early, as you suffer longer. So intervention of us is necessary for taking care of women and supporting ourselves in our lifetime. Here I wanted to show you how graphically you can see when you have reached it early, see how much you are suffering, and when you had chance to go to the right time, you will suffer this menopause symptoms and its complications for shorter time than these people. So we need really to be careful and listen to these people and watch them accordingly. So what are the most common symptoms? So a part of vasomotor symptoms, all of us, I think, we know what's called vasomotor symptoms. There are other complications that can arise from this stage of life. You know, this patient will complain of joint pain, muscle pain. They will start being attacked, the genitourinary tract, you know, they will suffer from that. And psychological symptoms will raise up. So it's really important to take care of our women and make them to avoid to go through this painful time. See, when you look at them, when they have reached this stage, 65.4, they suffer with joint and muscular, muscular discomfort. Vasomotor symptoms, it's about 50 to 75. You know, genitourinary symptom, more than 50, they will complain. They will tell you that when they want to go to toilet, they can't hold it anymore. They're always scratching themselves, you know. You know, they are disturbed when they are like in these events. And psychologically, you know, they will be disturbed. We will see it later, and you will see that around 25 to 55, they will get this mood irritability, anxiety, and they will suffer from primary psychological illness. So you can see these graphics will show you that how, in terms of hypertension, as I have said it a few minutes ago, how they are suffering. So here in Rwanda, we have stepped up and we started standing up against these complications from this stage of life. So maybe I'll take a time to congratulate and thank Professor Suda that took actions at King Faisal and opened the clinic that looking after these women. So he did a good job. Those are passing at King Faisal, you will see him taking action against these symptoms and complications. So when you look at this stage of life, around 84.8% in this country of ours, they are affected. So even if there is no menopausal scale yet we have established in this country, to use, according to the research done in 2023 by Dr. Sitin, he did a good job as well. Even if he deviated, he's now occupying himself with intrauterine admissions. So he's a maternal-fetal doctor now. But he did a good job because he was the first one to try and assess how menopause is taking site in our country. And he has discovered that around 84.8% they are getting affected. So here the scale he used was a Cooperman scale. So even if the symptoms, they are almost the same everywhere, but approach, medical approach, management approach, is individualized. So we'll see it later how we can approach them accordingly and according to the individual affected. So when you check in the numbers, around 96.2%, they present all of those symptoms. But when you see the moderate to severe, you see that number, if you remember the previous slide, it's still high. We shouldn't have that. So this 41.2, they tried to approach us, but only 2% that were helped. You see? So that's why I think Professor Subira has stood up. Yeah. So when it comes to vulnerable people with immunosuppressive diseases, it becomes very worse. It's very severe. You can see how, for example, people living with affected, not living. You live together with something you like. People affected by HIV, you can see how they are affected in terms of severity more than others, including as well people suffering from diabetes. So you will see that this menopause impact or complications is affecting them at the higher level than others. Sorry, I'm trying to catch up with time. So when you go through our sister countries, you can see that in Zimbabwe as well, they stood up by enumerating and assessing how people they get affected. You know, when you look at that article that was published by our colleague there, he saw as well that HIV people, they are affected more than others. So I wanted to emphasize on this slide, according to these countries I enumerated here, to show them that these special people should be taken care of in a special way so that they can survive longer as we wish to others. So what are we actually treating? You know, we went a little bit through it, but basically these are the things we need to treat. You know, when you get affected with this, there is changing in your body. So somatic changes. That's why that's where you start feeling hot flashes. You sit like this. We are sitting here. There is air conditioning in minus something, but you are busy sweating. You wiping yourself, and you go to sleep. You can't find sleep anymore. Others, they are just enjoying their sleep. You are awake the whole night. And in the morning, you are the one supposed to maybe to prepare the tea for your husband or for your children, you know, and you haven't slept at all, you know. You are suffering during your sleep. You are feeling pain everywhere. You can't find a position to sleep, you know. All of this, it's really complications of the menopause that we shall stand up against. So psychological. This is a huge thing to think of. You know, I don't abuse myself, but in Africa, we think mental health, sometimes we don't consider it. We cure ourselves. You know, we shall change this. We need to take care of our people in terms of mental health, because menopause can impact mental behaviors, causing depressions, irritability, and sometimes from those 2 points, you suffer from the third one, exhaustion. Urogenital is a serious problem. From my experience, you know, after seeing Professor Subira taking this, I tried to see people as well. And I've got a big number to follow monthly. From my experience, urogenital, we need to think of seriously, because not only to irritate the patient, but it causes trouble in the families. We've got too many divorces that we shall investigate. Can see some of the researchers here, Polyphile and Alice, they are good researchers. You shall stand on this and assess the impact of this according to the divorces we are getting in this country. And from my experience, after talking to them, I have discovered that everything starts from the bed. And in our culture, you will not tell your surroundings about your sexual behaviors. The children will ask you, you've been staying together for 20 years, and abruptly you are divorcing. You will not tell your children what's causing this. And the cause has started into bed. Yeah, we have it. So when we are even seeing them, please don't hesitate to ask about this, because it's a serious problem. Some people, they will go around before they will reveal to you that nothing anymore. You ask a husband, what's wrong with this? After 20 years, we're deciding to divorce. I say, no, she's behaving in this way. And they are going apart. They don't want to focus on that one. And one of the men has told me, you know what, when I try to enter, it looks like there is a roadblock inside. What's happened? And I can't resist on this anymore. It's been like 3 years on this. So I had to help myself aside, and then she catched me. And you know our women here, they are so jealous. You can't touch their husbands, you know. So I'm just emphasizing on this because dyspareunia, vaginal dryness, and blood symptoms. It's a serious problem affecting social behaviors in our families. So there is something also which is silent. You know, as doctors, we need always to be focusing and try to discover what is hidden. You know, they will not know what is causing. For example, you've seen many people reaching menopause stage. They start developing mild hypertension. The sugar starts raising up. And they start saying, I'm eating like this. You know, they don't know what's happening. It's because of this. Because there is a metabolic disturbance. The body can't regulate this anymore. And you, as a doctor, someone will come and say, okay, you've got hypertension, you've got that. Okay, take treatment. So let's be careful in terms of assessing the patient. Because these ones, they are silent. They will start degenerating in their bones. They will start developing cardiac diseases, as I have said. And sometimes they end up by going to Kizere there, you know. I'm always grateful to this country. You know the reason. If as doctors, clinicians, sometimes you don't think, but public health has thought already. There is a center there called Kizere. I don't know if you know it. I visited it and I was so amazed. I found there some of my patients. And they were thinking maybe it's other mental health, but probably it was coming from this stage. Because seeing a 55, 60 years old going to a Kizere, it's very rare. And since we caused with them, and we have started initiating some of the management, and you can see that they are getting better. So, colleagues, fellow world mates, let's focus on this and try to be a discoverer on this matter. So, scaling this, as I have said, this is the same like previous slide, but you need to know those 11 questions at least. We've got 11 questions to ask, and this will emphasize and will bring together all of those complications. Then you become a good doctor. So kindly, I humbly request you to know these 11 questions you are seeing here, and when you are examining the patient, assessing the patient, go through them at least to discover what is hidden, because, you know, culturally, aged, I will not say old, someone in advanced maternal age, sometimes you are a young doctor, like me, if I they will not tell you everything. Yeah, age is a number. So, what can we actually offer to them? You know, going through those symptoms and the diagnostic point, we need to classify on what to do to this patient coming to us. You know, so psychologically we need to offer. To release these symptoms, we need to offer. We can use medical or non-medical, pharmacological or non-pharmacological. But also not forgetting that each and everything in this world can have an impact, negative impact or positive. This medication we offer also can cause something if we don't pay attention and screen properly the patient. So that's why we need to categorize our patient in terms of age, obviously, because there are some limit, okay, according to the medication we've got around. So, but the aim was to make them to survive longer and with good health. So these are the trials that have been reviewed many times, and all of them, they have seen that the 51.7, it's a mini age, but all medication can be used if really we use them carefully. And after staging, after screening our patient, as I have said. So don't hesitate to start treatment as long as we set up protocols on how we can screen before our patient, even if they have got some chronic diseases. Because everyone must have right to the good health. So the most treatable problem is the one we never ask about. That's I have said it. You know, even in our culture, we sometimes get scared to ask somebody, do you have this problem, especially in regard of the sex. When you see she is older than you, but behave like a doctor, don't behave like a social treating. Okay? So we need to behave like doctors, and we need to ask carefully, yes, in a polite way, to our patient coming until we discover what is hidden. So when hormones are not an option, four things is still work. You know, as I have said, it depends on how we have screened our patient. So that's where we decide what to give and not what to give. Especially when you have decided to treat them. It means to initiate hormonal replacement therapy. If we have decided to initiate hormonal replacement therapy, we need to know what might be the complications. Which treatment might be less complicating or higher. So we need to know all of those. For example, for the people with chronic, she's 60 years, she's got diabetes, she had a history of DVT, you know, you need to know on which way we need to afford on this, to make them asleep, to give them joy when they're, to make them not wiping themselves when they are sitting, when they are in AC around. So we need to screen properly so that you can use some of the medication which are not hormonal, okay? So there is selective serotonin reuptake inhibitor, selective norepinephrine, gabapentin, all of those are the medication you can use to relieve those severe symptoms. So coming to this country, Rwanda already has the delivery platform, which it's really being grateful to this. I saw it when recently we had the discussions with the RSSB, Rwanda Social Security, to make sure the medications, the supplement, and everything is being paid by the insurance. So we haven't yet reached the agreement, but we are so hopeful because they can feel and understand this problem. Luckily enough, the boss of this department is a gynecologist, and he is a good man. He was helping us to see if something can be sustainable until they will decide to give medication to menopause people. So, and as well, what I want to tell you, the RSOG as well. I'm so grateful to RSOG because also they have initiated a platform to develop guidelines. I think we've been given a task, and we are looking at it, how we can develop guidelines that can be distributed all over the district hospitals as well. So seeing the Minister of Health is feeling it, it's giving me a hope, and I think it will come and respond to Dr. Subira's good willing. So what can we take in this matter as doctors, a part of thinking the budget or other sponsorship? So ask when the period has changed. If you receive a woman in approaching this, we need to ask all of those questions. Okay? Secondly, ask directly about sexual behavior. That's what I was saying. Don't be ashamed, or don't. Obviously, you find a way as a polite, as a young person like me in front of a higher aged patient. Score it. I think we will sit here in Rwanda and see how we can adopt a rating scale as well. I think in Africa, so far, Ethiopia and South Africa and Nigeria, they do have a rating scale, but all of us, we are almost like brothers. We are the same. We can use the same thing. The fourth, check the window. the best window to initiate this treatment is the best window is the time this complaint has started. The mean age is 51, but remember from our experience, we are getting 32, 34 in this country now, Prof, complaining of this. And when we check the ovaries, it's completely depleted. I don't know. Maybe we'll do a study as well and see what is happening. I don't know if it's a climate change. I don't know if it's other things, but we continuously seeing this kind of cases. So we need to treat the problem linked to sexual behavior. And lastly, we need always to check the vital signs, because one of the complications of the menopause is starting from vital signs changement, because obviously metabolism is being impaired. I think I prepared this 6 point for my colleagues to take it into considerations and use it when they are sitting in their clinical practice. So here I wanted to just motivate. A woman does not stop being our patient when she stops being fertile. When she stops being fertile, she's advisor to us. She's making us proud in different ways. You know, women's first. And when the women's they are put first, men's they are always proud. We live, our life is based on women. As men. That's why we need to take the first step to protect them. So I thank you so much for this attention, and I hope your kind questions or any other comments, they are very well welcome. Let me give the place to my colleague, Profil.
Thank you so much, Dr. Abdirinjiro. So now I need your advice. So due to time, I think we are on different time zone from the main hall, and they have started the closing ceremony. Thanks. Yeah, so we're probably on in a different planet. And what should we do? Yes, thank you so much.
This is the most important.
Which has been neglected for many years and ignored. Not only here, but even globally. So now let's have our panel. He's part of the panel. Yes, please. You have another mic?
I'm sorry to come up this abruptly. Thank you very much for a good presentation, and very much for lying, because I'm not a professor as yet. When we start with the word geriatrics, we should bear in mind that women, even a dog, are you in your jokingly important menopause? A very senior, internationally recognized surgeon. I looked at him, I was very much deeply offended. I'm everything but not a woman, but was offended. I told him, Doc, you wouldn't know that menopause is important until your bedroom doesn't work anymore. You wouldn't know that menopause is important until your wife has lost a job. Because menopause at the workplace. You wouldn't know that menopause is important until your wife at the age of 58, 60 is on walking stick. Sir, menopause is serious. Lastly, a very recent anecdote actually. A patient comes in front of me. She's overweight, she's crying.
3 monthly like that. Otherwise, we shouldn't be prohibited to treat our patient because of those history unless they are in active phase.
Thank you so much. So I would like to invite Dr. Jean-Paul to the panel and invite other panelists as well. Okay. So on the panel, I would like to invite Professor Anne Kihara. So she became a signature, and it's difficult to present a signature. In one word, she's a powerful women's health advocate, and she leaves her footprints everywhere, running in our veins to continue the legacy. I'd like also to invite Dr. Hani Fauzi. Dr. Hani Fauzi is a consultant obstetrician and gynecologist from United Kingdom, a global health leader, and a passionate advocate for women's health, with extensive experience in obstetrics and gynecology, public health, medical education, and you probably know Emonk. She's one of the initiators. So I'd like also to invite Dr. Alice Giraneza, my colleague. And Alice Giraneza is a Rwandan obstetrician gynecologist, clinician, and researcher with strong interest in improving maternal and reproductive health in Rwanda. And her work spans through important areas including obstetric care, post-abortion care, preterm birth, and improving quality of care in resource-limited settings. Dr. Alice specifically had seen how beautiful the government keeps designing guidelines for public health institution, and how there exists some mismatch with the private sector. And she was like, I need to make sure that the guidelines are consistent across all sectors. Thank you, Dr. Alice. I'd like also to invite Dr. Emi Wasonga. He's also a Rwandan gynecologist with a strong interest in improving maternal and reproductive health. Dr. Wasonga refused to leave rural areas to come work in Kigali because he wanted to serve the rural areas as well. Thank you, Dr. Wasonga. So on this important panel, maybe I'll start with Dr. Byiringiro. So menopause is sometimes surrounded by myths, stigma, and so many misconceptions. In the Bible story, in the Jewish culture, a woman in menstruation was unclean. That's what the Bible says. She's unclean. And now, after she survives all the stigmatization, after she survives all that, she enters menopause. Now another stigmatization starts. When will a woman feel that this world is home to her as well? How can healthcare professionals address such challenges, Dr. Byiringiro?
Thank you so much, Dr. Polyphil. I think the platform has been set, and it's up to us as a clinician to raise up our voice. And I think I've been saying it consistently. Some of our colleagues and seniors, they have thought about this, and they have stood up against this stigmatization. I gave an example of Professor Subira. I call him Professor. You can't practice for such long time and still serving your country, and you still be. A professor is a teacher. He has taught many people, including us, you know that. So I'm not really lying. To me, you are. So see how he stood up and he created a platform at King Faisal. So raising awareness in our population, it's something important to challenge this stigmatization. I think together as a clinician, together as public health and the Minister of Health, and having also government listening to its people, I think you can overcome this problem in this country.
Thank you so much. Now I'll go to Prof. Ann Kihara. Yeah. Ann Kihara, maybe part of your resume when we are talking about your bio, I think we should add the PPH Day. Yeah. I was there in Cape Town when you launched that day. It was launched by Prof. Ann Kihara, and she led the very job between and thank you so much. And Prof. Ann, are we doing enough to prepare young women for healthy aging, or are we waiting until menopause clocks in?
This is the most important session. And I'll start with FIGO. When I went into leadership in FIGO, I found the blanket, women's care, health care. That was the committee. And I said, until you disaggregate and have adolescent and youth, women of reproductive age, and the aging woman, you will not serve women right. I must be open. Do we have a guidelines or guidance from FIGO? No. Do we have guidelines from WHO addressing menopause? No. But let's all spell menopause. MEN-O-pause. So the men are being told, take a walk. I'm going through my own challenge. But I'm looking at it differently and saying, we've got to address why this is the case. Unashamedly. I've looked at legislature, I've looked at policies, I've looked at guidelines. High-income countries have menopausal guidelines, but each of them falls through a different professional body. In the UK, in Australia, in Canada. Where is the African story? And to be honest, women are seen and you say, hapa na pale syndrome. For those of you who are not Swahili, this is a woman who's come in with funny symptoms, untreatable symptoms. And you see this particularly in the rural villages. And she goes back dissatisfied. We're talking about a life course approach to women's health. We're very good at dealing with reproduction. We're miserable with dealing with perimenopausal and menopause. I'm there, so I can speak as a woman who has gone through it all. So we haven't done much. Climacteric has not been understood. Menopause is just an act of cessation of the period for 12 months without any other intervention. But let's also reflect as gynecologists. Are we doing surgeries and giving iatrogenic menopause? Yes. Is the environment and climate affecting and giving endocrine disruption? Yes. Are we giving fertility treatments for the IVF group? And even for the very young girls where we are harvesting from them over? What are we really in essence doing to some of these ovaries? And then there is the other scale, which I must speak, and you haven't researched on it. The self-image of women as we grow older. This middle part tends to get a little bit bigger. Why? Estrogen production. But more importantly, are we doing surgeries that are cosmetic inclined? So as you're looking at urogenital, can you also begin to look at the Botoxing that's all going on? In UK, it's rampant. When I have the sagging skin and my breast still start drooping, what am I doing? I want to go for lifts. I want to have facial lifts. I want to remodel myself. The woman in the village has got urogenital prolapse, but doesn't talk about it. The woman who's sitting somewhere like here because we didn't train on Kegel exercises, a little cough, she spats urine. Sexual, you are not going in depth, but I want to speak it bluntly. A sexual encounter becomes a urination encounter for quite a number of women because the sphincter control was lost. So are we doing enough? The answer is capital no. And it starts from literacy. To us as clinicians, are we having curricula that really is training on menopause and andropause, because it's there? Yeah? We don't. You have a minimal amount of energy put, even in our training schools. I'm in medical school, I'm teaching. Very minimal time is spent on addressing menopause and andropause. So if the clinician doesn't know, then how much more does the normal patient get informed or seek out services? Then look at the health system. Is it supportive? You go to the diabetic clinic, go to the cardiac clinic, go to the hypertensive clinic. Why is it we see women with late stage cancer? It's because between reproduction and between my geriatrics, nobody pays attention. So the next time I'm coming to you, I'm in stage 4 of cancer. There's no wellness clinic. You go to India, you go to Australia, you go to the UK, they have wellness clinics. So a woman is continuously followed through early detection, screening, early detection, diagnosis, management. So are we doing enough? No. I think I've justified it for you.
Thank you so much. Everybody has homework. We are not doing enough. At least for men, there is a whole department for prostate and the related issues. Yes. What about women? So we have a huge homework. And I totally agree with you. As a gynecologist and clinician in practice, little or no time is given to menopause. Now, talking about that, I know that at least for women who are educated and have the means, and who can afford to take that flight, can have care and attention somewhere else. And it leaves a majority, big number of women in primary healthcare services unattended. But also, not only about that, not that nearly all the fundings in the health sector is secured by women who are already in postmenopause, because they have lived that long to create that type of connection to shake funds. But when it comes to us, they shake money for us and we do nothing for them. Dr. Alice, how can the primary healthcare services bridge this gap?
Thank you, Dr. Porifir. I think Professor Kihara has tackled on it about the primary health care. First of all, the primary health care, the community health workers, nurses at the health center and the health post, general practitioners at the district hospital, they are the ones who see most of the patients. At the tertiary level, at the specialist level, we see fewer of the patient, a small percentage. So those healthcare providers at the primary level, they are the ones who need to understand that menopause is a life stage. after they understand that menopause is a normal life stage, they will be able to help women in menopause and perimenopause. First of all, I will break it into 4 parts of what is needed for primary health care providers to help women in menopause. First of all, they need to be able to identify, is this woman entering perimenopause or she's already menopaused? After she understands that, he will be able to help the woman. They need to know the 11 questions Dr. Biringiro was discussing about. Because women will be going to the hospital today, tomorrow, and after tomorrow, but nothing is done because the issue is about osteoporosis, secondary to estrogen deficiency. So she will be having back pain, fractures, and but no one understands the cause. The first thing for primary healthcare provider is to be able to understand, to identify those women. Another thing is, after identifying them, is to integrate the menopause care into primary health care. We integrate menopause care in the reproductive care, NCDs care, chronic diseases care, HIV clinics, because some complications are even related to estrogen deficiency or menopause at large. So primary health care providers in the different clinics at the primary health facilities need to understand menopause, and they integrate menopause care and do a holistic care for the chronic diseases and even the normal consultations. Another thing is about the screening. She mentioned that people come with the third stage, 4th stage cancers. Primary healthcare providers should be equipped with the skills to screen for cervical cancer, endometrial cancer, identify risk factors, and provide those screening services at the earliest, in order not to have the women in menopause coming with already advanced diseases. Another thing is about education. Yes, you've asked about 11 questions. The woman has issues with sexuality. She has issues with relationship, reproductive relationship. She has issues with mental, because menopause is associated with depression, with all the stress of hot flashes, poor sleep, and all that. So they need to be equipped with skills in educating women. How are you going to handle these symptoms? What can be done? Which lifestyle? The physical activity, supplement, calcium, vitamin D, and all that. But mostly what's more important is to give time to women when they come to the clinic. Try to understand, ask the questions. We see many patients who come to the private clinics because they hope it's where care is better, which is the other way around. We don't have equipment as the public has. But if a clinician there has to take some time to understand the patients, to understand the concern, to try to address the issues holistically, the patient will be satisfied. So primary health care is key, and if we equip primary health care providers with the needed means to take care of women perimenopause and postmenopause, we'll definitely tackle the issue.
Thank you so much. Speaking of that, I'll go to Dr. Hani Fauzi. Speaking of the resources, as Dr. Alice mentioned, what should be the priorities for quality menopause and geriatric gynecological care when resources actually are limited?
Thanks very much, Polyphil. I would like first of all to congratulate the society for really raising this issue and this topic. Rwanda has done a great job when it comes to maternal and child health. And here is the next chapter, really to looking after the women's reproductive age. I love the theme, healthy girls, healthy women, and indeed, this is the foundation for a thriving nation. Back to your question, in all fairness, say high quality care. It's very important to differentiate it between, so it's not equal to high cost of care. Quality is not necessarily cost related, is not necessarily expensive. And it's very important to have that mindset when we're looking to providing any particular services. So back to your question, I think I would really begin with not looking into what technologies are missing, what medicines do I need to provide for my setup. That would be the wrong way to start thinking, addressing this question. But I feel the mindset can be, what realistically can I do differently for women in this group in the setting that I have? And to that effect, I would like to approach the issue with 3 particular actions. To start with, recognize menopause. John Paul has given us a wonderful presentation, and I think we have all now agreed on it is not in any way a disease to start with. It's a phase, it's a transition. And I think recognizing it, the 11 questions are very good. Asking those 11 questions definitely get the conversation started. And I think I would really like to go beyond the sexuality. We need to ask a number of things that relate to the opportunity that you're seeing the patient at whatever stage, but particularly at that age. What are the profile risks for cardiovascular disease? The risk for diabetes, osteoporosis. These are elements, in all fairness. Recognize and assess these at a very early stage. The bone health, the mental well-being are very essential elements. So this, I would say, is my first R, respond. Recognize, respond. Responding to this at the primary health care setting, where if we keep the concept of universal health coverage, primary health care is the basis. I think the stage of health education, health promotion is really very basic. How we educate and how we sort of reassure. Back again to just perhaps more generic issues about lifestyle, about just advice on diet, on exercise. There are small elements that genuinely respond to the issues, and you will find that they relate very much to the 11 questions. What is so important in responding is we do it consistently and close to home, not have that sort of postcode lottery. If I go to this primary health care setting, I get these questions asked, I get some response to them, but in others I don't. My last R would be about referral and how we have to create a system by which there is going to be clear triaging. When we looked at the very early stage of recognizing the problem, looking into a pelvic mass, as an example, postmenopausal bleeding, issues relating to vulval disease, urogenital problems. There are certain things that you can do at the primary health care setting, but we need to have very clear triaging, referral pathways to help us understand this smaller subset. I would say less than 3% of people really need specialist care. We do not need to replicate these. So I have touched on 3 actions: recognize, respond, refer. I'd really like to add one last fourth R, which I learned, and I was quite impressed to see it as well, touched upon on this Congress: respectful care. Throughout all these stages, really have our empathetic listening in action and respect the person in front of us. I'll stop here.
Thank you so much. maybe that can make a mnemonic in responding to postmenopausal healthcare. Recognize, respond, refer, and always be respectful to the person in front of you. Thank you so much. The 4R. There's another R? Review. Review the data. We will make sure this comes as part of our reports. Thank you so much. Now, as we continue, to Dr. Wasonga, if you want women to live not just longer, but healthy and healthier than other generations and more fulfilling, what is the one change you believe we need to make in the way we provide gynecological care across the lifespan?
Thank you so much. One thing I think, but straight to the point, if I can summarize and to englobe all that, we need to think about a woman not just in a reproductive age, not only about pregnancy, family planning, or contraception, no. Go beyond that. By this, I think it will be achieved by doing this, incorporating this in the pre-service curriculum, such that we talk about it enough, we are equipped enough during our trainings, and also during our practice. So, socially, I think we have seen that interventions that improve quality of life are a bit neglected. From Joseph's presentation yesterday, you've seen that we have on the 3 centers, and when we talk about menopause, that was endometriosis. Then we talk, when it's about menopause, it is worse. Thanks to our seniors, Dr. Subira and Dr. Jean-Paul, for the initiation. I think this will be scaled up, be in social behavior change in our communities. You've heard a lot of preachings about oral health, about alcohol and others, but we are not talking about the menopause. So we don't want menopause symptoms to demean our senior citizens in the cabinet, in the conference rooms like these. So we have to move and make a change. So as my colleagues mentioned about the RAs, I agree with them. But again, back to the social aspect. Everyone in this room, if I may ask you, do you go back to your elders in the upcountry and be near them? For as he mentioned, I'm always treating people in the upcountry, but you prescribe, due to cognitive decline, they are not complying enough, and they have sons and grandsons, but they are not there for them. So please, socially, though we are in a busy world, but try to look back and help our senior citizens, the women and men. We don't have only to think about menopause only. We have, it has to go with andropause as well. So we have a lot of sayings in Kinyarwanda. So it's not because they are that disturbing, but there is cognitive decline, there are mood changes. We just have to understand, listen to them. And again, during our consultation, it's like some of our colleagues harass them. You know how they describe those symptoms. So let us try to understand them. And let us involve the ecosystem around the system, and even the relatives who should help. As I just gave a request to everyone in the room to make sure that you at least call them daily to know how, if they are complying, if they have new symptoms, and encourage them to visit. They take some time without visiting. They usually show up very late. And I attribute this to us who are still in young age. So, in a nutshell, let us involve this in our pre-service curriculum. Let us emphasize and think about it during our practice. Let us also have social behavior change and public health involvement in this. Thank you so much.
Thank you. Thank you so much. If I heard very well, and you can add more, if I heard very well, our 5 panelists summarize very well what we really need. We don't need to go beyond that to start thinking of healthcare. So our panelists shared with us that we need to incorporate the menopause in the curriculum. And as we learn about menopause, and not only menopause, by the way, also midlife women's health, we need to expand access to care, and we need to ensure that the primary healthcare services is equipped and financed, and information is available to all those women. And from here, Dr. Ann Kihara stated and reminded us that women's health in postmenopause needs to be once again, or probably the first time, on health policy agenda. Let it shine there. We need it there. And now, from here, from this panel, we have the 5 R that we can use always where we are to ensure that the health system recognizes service delivery for postmenopausal women, financing, programmatic interventions, and across the life course. Recognize, respond, refer, respectful care, and ensure you review the data and updates. Thank you so much. And if you have one word, each panelist, that you would want to add, please add one word.
Thank you, Porfir. The one word I will say, as together, let's put women's life first.
For me, we recognize the lifespan of a woman is extending. Make it healthy. I don't want to talk about disability-adjusted life, but quality-adjusted life. Twilight age does not mean I cannot be productive and contribute to society.
Few words. I just remind ourselves with the African say, if you want to go fast, go alone. If you want to go far, get together. Thank you very much, Rwandan Society for Obstetrics and Gynecology, for bringing this topic into the mix, and congratulations for all the work you have done before as well.
I will say, as obstetricians and gynecologists and all healthcare providers, let's all treat patients as whole. Let's do the holistic care. Thank you.
Let us improve social behavior change and communication to improve awareness of postmenopause and menopause.
Social behavioral changes. Thank you so much. On the African continent, we have, I think, 3 countries that have recognized Menopause Society by the International Menopause Society. And I was very honored to be the founder of the Rwanda Menopause Society when it started. And I invite everybody to join the society and expand what we just got from this panel today. Thank you so much, and another round of applause to our panelists. Thank you so much.
Thank you very much, Dr. Polyphil, and a great panel. We really appreciated the session. Thanks a lot. I I am sorry we did not give audience questions, but we have lunchtime. You can approach each other's and take more questions.
We are coming to a close of the event here at the breakout room, as well as in the main hall. Let's just give you a small summary of what's happened here for those of us that were not present in the since earlier. We had a talk from the Zhejiang University School of Medicine. They were promising collaboration and visits, and also showing interest in having medical students and residents coming to learn more on their maternal-fetal advancements, especially on birth defects. And they were also encouraging us to join in the training and exchange programs. We also had a talk from the birth care medical technology for their innovations. They have a booth upstairs, so if you want to check them out. And other than that,
yes. Yeah, we also had the Global Financing Facility talk. That was really nice. And I will just tell you, as we are reaching the end of the conference, this is the last chance we have. Please take contacts. You can scan the badges for quick contact sharing. There is a QR code for that. Take all the contacts. After lunch today, some people will disappear. We will not see them again.
yes. And okay, now we were all present for this menopause talk. This was very, very interesting. For some of us that are still very young and do not see this type of cases, it was a quite interesting talk. And it's important, it raised awareness for some of us. And also, now we have a mnemonic. We have to recognize, respond, refer, respect, and review our patients, regardless, but mostly for these mothers and grandmothers that we have. Thank you very much. For now, we have a QR code here that is very important for the review of the whole conference. Give us feedback for what you thought about this whole conference. And I hope everyone now has their meal card. We can now go for our lunch, I think. Yes.
If you don't have the meal cards, please refer to us. We have them at the back. As you saw yesterday, they don't accept that you proceed without. Thank you very much, and enjoy lunch. Well, I think we missed the closing ceremony. We can just go directly for lunch if... Yes, so, and one more thing, the medical technology presentation, they actually have a booth, interesting, out from the main hall. If you want to check some of these devices, they have them there. And you can try them even on the dark skin to see if jaundice can be detected. Thanks.